Hello, doctors. Today we are going to study about pneumonia, a respiratory condition that ranges from mild infection to life-threatening illness, especially in the elderly and immunocompromised patients. So let's move it forward to the topic. Pneumonia, it is an infection of the lung parenchyma leading to the inflammation and consolidation of the alveolar spaces, caused by bacteria, viruses, fungi, or aspiration of foreign substances. So, pneumonia is an infection in the lungs caused by bacteria, virus, or fungi. It causes our lung tissue to swell up like inflammation and can cause fluid or pus in the lungs. So, bacterial pneumonia is usually more severe than viral pneumonia, which often resolves on its own. So, this is what the basic introduction of what is pneumonia. So the most important thing you have to know here is what is the difference between the viral pneumonia and bacterial pneumonia. So all pneumonia is the inflammation caused by an infection in the lungs. So the patient may have different symptoms depending on whether the root cause is like a virus, bacteria, or fungi. So bacterial pneumonia tends to be more common and more severe than viral pneumonia. It is more likely to require a hospital stay. So we have to treat the bacterial pneumonia with antibiotics. Viral pneumonia causes flu-like symptoms and it is more likely to resolve on its own. So you usually don't need any specific treatment for viral pneumonia. So this is what the difference between what is viral pneumonia and bacterial pneumonia. So now let's move forward with the classification. So we categorize pneumonia by which pathogenesis like viruses, bacteria, or fungi caused it and how the patient got it. So it can be community acquired or hospital acquired or ventilator associated pneumonia. So that is the types of pneumonia. One is community acquired CAP, hospital acquired HAP, ventilator associated or aspiration pneumonia. So community acquired pneumonia is like when you get pneumonia outside of a healthcare facility, it is called a community acquired pneumonia. It is like the causes can be bacteria, virus, fungi, or protozoa, etc. In bacteria, it can be because of the infection with streptococcus pneumonia bacteria, also called as pneumococcal disease. It is the most common cause of community acquired pneumonia. And the pneumococcal disease can also cause ear infections, sinus infections, and meningitis, etc. The Mycoplasma pneumonia bacteria causes an atypical pneumonia which usually has milder symptoms. And other bacteria that causes the community acquired pneumonia includes Haemophilus influenza, chlamydia pneumonia, and Legionella. So these are the other types, other bacteria that cause the CAP. Then the virus. So under the community acquired pneumonia, the first one is bacteria, next is virus. Virus that causes the common cold like the flu, influenza, respiratory syncytial virus like RSV can sometimes lead to the pneumonia also. Fungi, it is like molds. Fungi like Cryptococcus, pneumocystis, etc. are uncommon causes of are like a common causes of uncommon causes of pneumonia. People with compromised immune system are more at risk of getting the pneumonia from a fungus. Okay, so that is the fungal pneumonia. Next is protozoa. Protozoa is like rare condition. Protozoa like toxoplasma causes the pneumonia. So these are the causes which does cause the community acquired pneumonia. While talking about the hospital acquired pneumonia, that is HAP, you can get hospital acquired pneumonia while in the hospital or healthcare facility for another illness or procedure. So it is usually more serious than the community acquired pneumonia because it is often caused by the antibiotic resistant bacteria like methicillin resistant Staphylococcus aureus. So this means hospital acquired pneumonia can make you sicker and be harder to treat. And the healthcare associated pneumonia, that is the one of the subtype of HAP, that is HCAP, healthcare associated pneumonia. You can get a HCAP while in a long term care facility such as like a nursing home or outpatient extended stay clinics like a hospital acquired pneumonia. It is usually caused by antibiotic resistant bacteria, that is the cause of HCAP. That is the HAP. And next is ventilator associated pneumonia. So ventilator associated pneumonia, if the patient need to be an respirator or a breathing machine to help to breathe in the hospital, usually in the ICU, the patient at risk of ventilator associated pneumonia, VAP. The same type of bacteria as community acquired pneumonia, as well as the drug resistant kinds that cause the hospital acquired pneumonia, causes the VAP. The VAP in the sense VAP, ventilator associated pneumonia. Last one is aspiration pneumonia. Aspiration pneumonia is like, aspiration is when solid food, liquids, spit or vomit go down on the trachea, that is the windpipe, into the lungs. So if like the patient can't cough these up, the lungs can get infected. So this is due to the inhalation of the oropharyngeal content. So these are the 3 or 4 types of classification of pneumonia: community acquired, hospital acquired, ventilator associated pneumonia, and aspiration pneumonia. Next is the etiology. What causes uh, the CAP, HAP, VAP, and aspiration? So aspiration, as you know, it is because of the inhalation of the oropharyngeal content. CAP, as I have mentioned, most commonly caused by Streptococcus pneumonia, Haemophilus influenza, Mycoplasma pneumonia, respiratory virus, etc. And HAP and VAP is mostly involve the resistant organisms like Klebsiella, Pseudomonas, MRSA. So these are the causes of HAP and VAP. Next is the risk factor. So the patient is at increased risk of pneumonia if the patient is over the age of 65 and or under the age of 2, and and living with a lung or heart condition, example like cystic fibrosis, asthma, COPD, emphysema, sarcoidosis, etc. And if the patient is having a neurological condition that makes swallowing difficult, conditions like dementia, Parkinson's disease, and stroke increase the risk of aspiration pneumonia. Next is the if the patient is in the hospital for a long term care facility, then that is also one of the risk factor. Smoking, or if the patient is pregnant, or if the patient is having a weakened immune system, then if the patient is having a weakened immune system, or if the patient is on chemotherapy or organ transplant recipient, are living with HIV, AIDS, or taking any medication that suppresses the immune system, so these are also at the risk factors of getting diagnosed with the pneumonia. Next is the pathophysiology. So pathophysiology, as I've mentioned, due to the infection, it can lead to immune response to neutrophilic exudated alveoli and leads to consolidation. And there will be gas exchange will be reduced, and it will lead to hypoxia and dyspnea. And you can all due to this, you can see the clinical signs like crepitations, reduced breath sounds in these conditions. So pneumonia, this is how the pathophysiology, due to any inhaled or aspirated pathogenesis, there will be immune activation and they will lead to alveolar inflammation. This alveoli will fill with exudate, will leads to consolidation, or if there is an impaired gas exchange happening, it leads to hypoxia. So this is what happening in the pathophysiology of pneumonia. Moving on to the clinical presentation, clinical features. Symptoms of pneumonia depend on the cause. So symptoms can range from mild to severe. The patients or babies, young children, and older adults may have different symptoms. The typical symptoms are like symptoms of bacterial pneumonia can develop gradually or suddenly, which will include fever or up to 105 Fahrenheit or etc. And cough with yellow, green, or bloody mucus, tiredness, rapid breathing, shortness of breath, sweating or chills, chest pain, abdominal pain, especially with coughing or deep breathing, loss of appetite, bluish skin, lips or nails, cyanosis, and confusion or altered mental status, etc. So this will be in the clinical features of bacterial pneumonia. If the symptoms of viral pneumonia will be usually develop over several days, and it will include dry cough, headache, muscle pain, extreme tiredness or weakness will be present in the viral pneumonia. And in cases of young children, if the young children is affected with pneumonia, the babies and newborns may not show any symptoms of pneumonia, or their symptoms may differ from adults, like fever, chills. There will be cough, difficulty in breathing or rapid breathing, loss of appetite, vomiting, lack of energy, restlessness or fussiness. So you can also see a few signs. You can look at the babies and young children's, like grunting sound with breathing or noisy breathing, a decreased amount of pee or diapers that are less wet, pale skin, limpness, crying more than usual, and also you can see difficulty in feeding. So these are the signs you can see in babies and young children. And the symptoms of pneumonia will be different in adults over the age of 65 years. So adults over the 65 years are, or those with weakened immune system, they may have a mild or less noticeable symptoms of pneumonia, like cough or shortness of breath. The symptoms of ongoing health conditions may worsen, and the older adults may experience a sudden change in mental state, fatigue, low appetite, etc. So, these are the features, clinical features you can see in the bacterial pneumonia, viral pneumonia, and in the babies and newborns, and in the adults over the age 65 years, and also the patient with weakened immune system. Okay, I hope you got an idea of what are the clinical features of pneumonia. Moving on to the diagnosis. So, in the physical examination, you can see decreased, you can hear on while auscultation, you can hear decreased breath sound, dullness on percussion, there will be crepitations, then bronchial breath sounds can be heard, and echophony. It is like these are the classical auscultatory findings in the pneumonia. And chest x-rays, you can see, you can confirm the consolidation, and cbc you can do leukocytosis with neutrophilia. It will show cbc will show infection response, and sputum and blood cultures can be help to guide the therapy, especially in the hospitalized cases. And pulse oximetry assess the oxygenation. And you can also do procalcitonin, that is optional biomarker for bacterial infection. So it is an optional case. If you want to do in case of bacterial infection, you can do the procalcitonin. So this is the ways how you can diagnose the condition of pneumonia. Next important thing is curb 65 score. So it is like a validated score to stratify the severity and decide between the OPD versus the IPD care. So to assess the severity and check for the need for hospitalization, you can do the curb 65 score. And if the score is 0.0 to 1, you can do it in a OPD level. If it is the score is 2, you can consider as admission. And if the score is greater than or 3, equal to 3, hospitalize and consider ICU. So this is very important thing. You can make a clinical decision while you're doing this curb 65 score. You can check for that. You can do, if there is any confusion while diagnosing, you can go for urea, respiratory rate, and BP and age. So in these I have mentioned the levels also. If it is greater or less than of any of these condition, then you can go for a curb 65 score. And based on the score I have mentioned, like score 0 to 1, you can do it in OPD level. Scores 2 greater than or equal to 2, consider hospitalization, or if it is greater than or equal to 3, you can do the urgent inpatient care. So that is the curb 65 score. Moving on to the OPD management. So how you can manage the patient of pneumonia in OPD level. So treatment for pneumonia depends on the cause. and it can be bacterial or viral or fungal, and how serious your case is. In many cases the cause can't be determined, and treatment is focused on managing the symptoms and making sure the condition does not get worse. So for the patient who are hemodynamically stable and can tolerate oral therapy, and also for so the for stable patients, so OPD management for a pneumonia case, you should indicate only for the stable patient with the mild symptoms. First one is for patient who is hemodynamically stable and can tolerate the oral therapy like medications. First line of treatment, you can advise antibiotics, amoxicillin 500 mg TD for 5 to 7 days, or azithromycin 500 mg OD for 3 days. Second thing, supportive care. For fever, you can advise paracetamol, steam inhalation, oral hydration can be advised. Next, follow up after 48 to 78 hours. So this is how you have to do the OPD management of the pneumonia case. Emphasize the supportive care and follow up within 48 to 72 hours compulsory. So this is the three important thing you have to do while doing the management in the OPD level. It is make sure it is keep in mind it is indicated only for the stable patient with mild symptoms and can tolerate the oral therapy. Then if the patient is comes under these categories, then you can go for the OPD management of pneumonia. Moving on to the IPD management, when you have to do IPD management, as I have mentioned, the curb score, curb 65 score. If the score is greater than or equal to 2, go for hospital admission. Hypoxia, check for SpO2. If it is less than 90%, go for IPD admission. And if the patient is having an altered mental status, you can go for that. Sepsis sign, go for admission. Failed outpatient treatment. So if the patient is not, even after the follow-up of 48 to 78 hours, the OPD level of treatment is not working for the patient, then the patient is advised to for admission. And the treatment start with IV antibiotics. You can go for ceftriaxone 1 to 2 gram IV OD with azithromycin 500 mg IV OD. Consider piperacillin, tazobactam, or meropenem for HAP, that is the hospital administered pneumonia. That is the IV antibiotics. And the combination of beta lactam plus macrolide, that is the ceftriaxone and azithromycin can be advised. And second point, oxygen therapy to maintain the SpO2. So the SpO2 level should be maintained. It should be greater than 92%. IV fluids, antibiotics can be advised. Monitor the vital oxygen fluid status and response. Blood culture should be done, and ABG should be done if the case is very severe. So this is how you have to manage the condition, the IPD level. So keep in mind about the indication of IPD management in the certain points which I have mentioned in the slides. So this is how we have to do the management of the pneumonia case in the OPD level and the IPD level. Moving on to the complications. So these may occur, the complications may occur if the treatment is delayed or inadequate. So if the treatment is not done properly, or if it is delayed, you can see these complications: pleural effusion, emphysema, empyema, lung abscess, respiratory failure, sepsis, ARDS. So these are the complications of the pneumonia. And in the cases of special population, pneumonia like in elderly is like may present with confusion or falls. So in that may lack fever or cough. So these are the special population cases in elderly and in immunocompromised. So those who have weak immune system may suspect an atypical organism like fungal and PJP, that is a pneumocystis girovesi. So that is PJP and fungal. And early treatment is more often more aggressive and based on risk of resistant organisms. So this is the special population, that the elderly and immunocompromised. So we have to take a little extra care to these patients. Moving on to the prevention. So how you can prevent pneumonia? First, pneumococcal vaccine, important. Influenza vaccine yearly. Advise them no smoking. Early treatment of respiratory infection. So for any respiratory infection they are going through, ask them to get an early treatment. Patient education, very important. Ask the patient to complete the antibiotic course. Watch for red flags like worsening breathlessness, high grade fever, etc. Ask them to rest and come, or like ask them to have a regular follow up with their health. Encourage hydration, and it is very important of completing the antibiotic course even if the symptoms improves. And so these are the ways you can advise and educate the patient to prevent from getting diagnosed with the pneumonia. Last but not least, the summary to wrap up the topic. Pneumonia, as I've mentioned, is a common treatable lung infection. It requires an early diagnosis and risk stratification. Classify based on the setting, CAP, HAP, or aspiration. Use CURB 65 score to decide whether to treat the patient at OPD level or the IPD level. Empirical antibiotics are very effective if started early. Prevent with vaccines and public awareness. Treat early with appropriate antibiotics and monitor for complications. So this is the important points of our topic, pneumonia. So let's wind up for today's session. I hope you guys got an idea of what is pneumonia and what are the classifications, how we have to differentiate the treatment in the OPD level and IPD level. So thank you so much for patient listening.